Ladies and gentlemen, please welcome Grantmakers in Health Vice President for Program and Strategy, Osula Rushing.
Welcome back. I hope you took advantage of the wealth of programming earlier this afternoon, our plenary session on centering equity in pandemic response and recovery, our breakout and networking sessions, and our on-demand quick takes, which are ready for you whenever you're ready for them. It's my great honor to introduce our final plenary of the day, Reprioritizing Public Health. Support for this session was provided by the W.K. Kellogg Foundation, and the discussion will be led by Laura Gerald, who is president of the Kate B. Reynolds Charitable Trust in North Carolina and is the vice chair of GIH's board of directors. Laura, I'll turn things over to you.
Thank you, Osula. And good afternoon, everyone, and welcome to this afternoon's plenary session on reprioritizing public health. I'm so glad you could join us today for what will surely be a relevant and riveting discussion. I have the pleasure of moderating this session, including fielding questions from the audience that I hope you will feel free to put in the chat room at any time. We really want you to join our discussion today. But now I have the pleasure of introducing our distinguished panelists, both with deep experience as public health champions and practitioners. Dr. Anthony Iton is Senior Vice President for Healthy Communities at the California Endowment. Previously, he served for 7 years as the Alameda County Public Health Department Director and Health Officer. He's also an internal medicine and preventive medicine physician. Dr. Mona Hanna-Attisha is founder and director of the Michigan State University and Hurley Children's Hospital Pediatric Public Health Initiative, an innovative and model public health program in Flint, Michigan. She is a pediatrician, perhaps best known for her groundbreaking work in uncovering the Flint water crisis and leading recovery efforts. To frame our discussion for today, crises like the COVID-19 pandemic tend to highlight the importance of public health and the cost of failures to invest in public health infrastructure, including its workforce, in between crises to prepare for and perhaps even prevent the next one. Inequities in the burden of disease often stem from broad social and systemic failures that, frankly, public health has failed to address. One of the reasons we need to reprioritize public health is so that it can better engage in the kind of policy and systemic change that's needed to address health equity, which as of 2020 at least is at the center of the 10 essential public health services framework. On a more hopeful or positive note, public health functions and advances such as the development of vaccines and subsequent vaccinations seem to be helping us to win the fight against COVID-19. Further good news is reflected in increased interest in public health among undergraduate and graduate students. Yet for many in our audience today who are working toward better health through better philanthropy, working with state and local public health agencies is not a significant part of our work. It can be fraught with challenges, one of which is the decentralized and varied nature of public health infrastructure at the state and local levels. So why don't we then start our discussion today by having each of you describe your experiences and background in working with or in public health and describe how it is structured in your respective states. Let's start with Mona.
Thank you, Laura. Thank you, Osula. Thank you to everyone who is here today as part of this conference. You know, I think it's an understatement to say this has been an unprecedented time, and I wish I could be here in person with all of you and consider this as like a hug out of my box into your box. But I just want to kind of express my gratitude for the work that philanthropy has been doing throughout this pandemic and has really kind of stepped up in a tremendous way to fill the gaps where maybe public health should have filled the gaps or where government should have filled the gaps. So, you know, just a first off, kind of thank you to all of you for the everyday work that you are doing and especially have been doing this past year and a half. So Laura, that's a great question. You know, public health means a lot of different things to different people. I think if you ask 10 different people, like, what does public health mean to you? And what is public health? What does it do? You'll probably get 10 different responses. And that's actually kind of what I love about public health, because it's so broad and it does mean different things to different folks. And, I'm a public health pediatrician. Well, what does that mean? Well, for me, I define it my own way, and I get to kind of dip my legs into the world of medicine, but I also get to dip my legs into that population level space. So it's about, not what we often equate health with. It's not healthcare. It's not that one-on-one. That so often I think people, when they think about health, they equate it with healthcare, but it's that ability to take a step back and to open our eyes and to look at things differently with a different perspective, and to see often the kind of the root causes and the upstream issues that truly address whether a community or a population is healthy or not healthy. It's about being proactive. It's about being preventative. It's about keeping kind of a pulse on that population. And you're right, Laura. We for decades have been living in this kind of austerity-driven disinvestment of public health, which hasn't happened by accident. I think we can kind of trace a lot of the reasons why we have lax regulations, why we don't have robust support of local, state, and federal public health. And I hope that this pandemic, like many public health crises that we've been through, will finally give us this opportunity to kind of open our eyes to the ill effects of this chronic disinvestment in public health, and finally get us to working in a system or a society that values prevention and these proactive efforts. And I'm hopeful, but I'm always hopeful, but I'm especially hopeful right now. So you also asked kind of how it runs in my state. So I'm in Michigan. We have local health departments, and then there's a state health department. There's a lot of kind of academic government partnerships. My work, I'm an academic. I work for a university, but our work is hand in hand with so many partners, from government, from local public health, with state public health, with federal public health, but also with other kind of, on the ground community partners. So, there's disinvestment in my state, in my local health department. Our local health department is supported by a local tax base, and in areas where that isn't very, where that's not strong, like in my community, it's always a competition of resources, which is kind of unfortunate. So, I think it's similar in many communities, and I think just broadly, it speaks to, once again, the lack of prioritization, this chronic lack of prioritization of public health, and a need to really flip that switch.
What about you, Anthony?
And I also want to thank GIH. Good to see my old friend Osula. And it's always a pleasure to be on a panel with Dr. Mona Hanna-Attisha. We did a little something together at APHA this year too, and she's become one of my favorite public health pediatricians.
Same. We're besties. We're pretty much besties right now.
And it's good to see my friends, not see you quite frankly, because I can't see you right now, at Grant Makers in Health. And so hello everybody from your little computer screens to my little computer screen. So, I think that for me, this year was kind of tragically wonderful in a sense, because it brought me back to my roots in public health. And when I left the Alameda County Public Health Department about 12 years ago now, I had an exit interview with the local newspaper, and they asked me what my greatest regrets were. And at the time I said, I think I failed. I failed to build a political constituency for public health, a political constituency for prevention. I thought throughout most of my career in public health that good data and good sort of public health arguments would win the day. And what I learned through that period of time was that public health is very political, and it operates in a government system that is constrained. And when you when you analyze why public health gets very little attention, it ultimately comes down to the fact that there isn't a meaningful political constituency for prevention. And we constantly found ourselves, basically being overrun by health. Alameda County has a big healthcare system and a very liberal constituency. And when people showed up at the Board of Supervisors, it was around access to healthcare, which is a very laudable goal, but it doesn't take into consideration all of the upstream work that's necessary to keep people from needing that healthcare in the first place. And there wasn't a ready political constituency to argue for that. When COVID-19 came around, and I'm very proud of philanthropy in California, 21 foundations came together and created a pooled fund at the Public Health Institute to help the state and localities respond to COVID-19, and in particular to help fill some of the gaps around so-called hard-to-reach populations, around folks that were being disproportionately impacted by COVID-19. Our goal was to initially to help the state stand up a contact tracing workforce that reflected the demographics of the communities that were most impacted, both economically and through morbidity and mortality of COVID-19. And in those initial discussions, a number of the foundations said, look, we have no idea what public health does. We have no idea how to even assess these various proposals that are coming to us for COVID support. You, the California Endowment, seem to have a pretty good sense of what public health is in California. Can you help us figure this out? And that's what led to us taking the lead with some of our other sister foundations in crafting this pooled fund at the Public Health Institute, ultimately, which raised $35+ million to help support the state and local response. Now, the structure of public health in California is a little bit unique. It's not completely unique, but there are 58 counties in California, from Los Angeles all the way up to Modoc. Los Angeles, 10 million plus people. Modoc, maybe 15,000 people. Each of them has a physician health officer by law. And then there are 3 city health departments, Berkeley, Pasadena, and Long Beach in California, that each have their own health departments. And actually the Berkeley Health Department is the oldest health department in the state of California. Those health departments, 61 jurisdictions, are all led by both an administrator and a physician. And when it comes to a communicable disease outbreak, and I'll just, just for the sake of it, just give you a sense of a typical public health department structure has 5 elements to it. It has communicable disease, it has chronic disease, it has environmental health, inspecting restaurants and all that kind of stuff. It has emergency preparedness, oftentimes taking many different configurations. And then it has maternal and child health. So that's a typical structure for a public health department. When it comes to a communicable disease crisis, tuberculosis, COVID, having physician leadership is absolutely critical, because you need to have credible spokespeople about what's happening in the community. So California's structure is uniquely beneficial to an outbreak like COVID, and it proved itself to be effective. We were the first to essentially issue county-wide orders to shut down the economy, to try to anticipate and mitigate the impacts of COVID-19. My colleague in Santa Clara County, Sarah Cody, was the first person in the country to issue an order, and she rallied 6 or 7 Bay Area counties to work with her. The state, Gavin Newsom, followed the Bay Area, and then Los Angeles followed the state and the Bay Area. So having that physician leadership, credible physician leadership, and then the political leadership to support that was absolutely essential in California. And I believe that the Bay Area did well in COVID-19 because of that leadership. So a lot of our colleagues in philanthropy had a hard time understanding, how do we even work with local counties? How do we work with the state? Working with a county is not an easy thing. It's a government entity. It's politically governed. Decision making is sometimes nebulous. It's murky. Who makes the call on shutting down? Is it the health officer? Is it the health director? Is it the board of supervisors? Is it the county administrator? And if you ask the 58 counties in California who makes that decision, you would probably get 58 different answers. By law, it's really the health officer. But no health officer can do that on their own because they need the instrumentalities of government to essentially enforce all of that. So it's a complex dance, and philanthropy has a hard time funding government in general, and then trying to discern how to be most effective working with local and state government is oftentimes a matter of just trying to find people who know the intricacies of those systems and having them lead the way.
So it's interesting. You both mentioned prevention in your comments, but we are leading with crises. So I get that. We're going to go back though to prevention before the conversation is over, but let's continue to lean into the crises a little bit. So I hear you, Anthony. What you're saying is that it helps to have good public health leadership. In your case, in California, physician leadership was very helpful. And I also hear that for those of us who are doing collaborative funding among foundations, it also helps to have a California endowment with an Anthony Eiten who has such a strong background in public health to help folks navigate it. I suppose not all states are that fortunate, but that's good information, sort of having someone who knows public health to help us understand how to intersect with it is very helpful. But I'm glad that things went well in California. Mona, I've heard you talk about your experiences with the lead poisoning situation in Michigan, where things in that crisis obviously did not go so well. We could spend a whole hour talking about that experience. I get it. We don't have that time, but folks can read about it in your book, What the Eyes Don't See. That's my own plug for you there, Mona. She did not ask me to mention that, but it's a riveting story. But to focus on the public health aspects, one of the main functions of public health, any local public health department or otherwise, is assessment, surveillance for public health threats to try to prevent those. But it seemed in your story as a practicing pediatrician, you had to take on that function yourself in the Flint water crisis of assessing and finding a threat. Could you just tell us how that experience shaped your thinking about public health and sort of give us a little bit more about how maybe things didn't go so well in a crisis with public health in that instance?
Yeah, thank you, Laura. So, I'm a pediatrician in one clinic in Flint, and I can tell you about how my patients are doing. And I can tell you about, for example, their blood lead levels. But I can't tell you about how a population is doing or how trends are happening at a population level. And that's one of the biggest differences between medicine and public health. Once again, it's this ability to take a step back and to see how the population is doing. And in my situation, I knew that blood lead monitoring was part of surveillance systems. And I tried to get that surveillance data because remember, I'm just one clinic, one doctor in one clinic. I can tell you just about my clinic. And I couldn't get that data from the local level or the state level. And there was kind of roadblocks in every way. I asked the local health department, can you, this is epidemiology 101, like, can I get this surveillance information? And the response was like, we can give you one PDF result of one child at a time. I'm like, that's not surveillance. That's not how you track problems, identify problems early, intervene, and similar issues at the state level. And we had issues with surveillance in the beginning of COVID as well. So because of this lack of investment in public health infrastructure, these surveillance systems are outdated. They haven't, they're not the most robust technology. It takes a while to get information. So there has not, once again, been that investment in these surveillance systems. So I don't blame these entities for not having the information. It's really been these policies or lack of investments that have made it difficult. So when that wasn't available, then me as an academic, as a physician, kind of stepped in and kind of did what public health should have done. And academia in this situation, and this kind of small public hospital doctor were kind of the checks and balances to complement public health. But that's not how it should be. And fortunately, we were able to lean on kind of robust electronic medical records. So maybe there's an opportunity kind of for partnership, because there's some really good high tech that can work with local health departments. So there's lessons learned on how we can do it better, but we definitely need more robust systems. And we need to do better for people outside of public health to get what they need from public health. It shouldn't be roadblocks. It shouldn't be FOIAs. It shouldn't be like threats of multiple forms and IRBs. I mean, some things are there for important reasons, but if somebody out in the community is worried about some public health issue, it should be transparent. It should be quick. It should be timely to be able to get the information to take action to, quickly identify a crisis and then abate it.
And so, again, the epic failures that happened there in public health are widely publicized, but it seems like in part you have basically just started your own public health initiative, again, in conjunction with your academic center and your hospital. But you mentioned partnerships. So I assume there are many other partners that are, now working together, I hope better.
Yes, absolutely. They're scared of me now. Yes. No. But we work very hand in hand with all levels of governmental, public health, but also with all these other agencies and partners and parents and children, community members to do this work. The work of public health it is not in silos. It's not just in academia. It's not just in government. It is about, and not in philanthropy. It is all of us working together to do this work.
Partnerships. So with that said, in Michigan, can you think of specific ways that philanthropy helped to support your work and this sort of more collaborative effort there?
So many ways.
Yeah.
But real quickly, when I released my research sharing, oh my God, there's more lead in the blood of children, and finally it kind of helped expose this crisis. And there was a lot of like, well, who's going to do what? And there was like, what should government do? What should philanthropy do? Philanthropy is like, well, this is a government problem. Like, they need to fix the water. And government's like, well, we can't do this all alone. We need philanthropy to help. And the C.S. Mott Foundation, which is based in Flint, did something unprecedented. They paid $4 million to switch us back to Great Lakes water. And, they never in their history would have imagined doing something that government was supposed to do. Like, isn't that like part of this kind of social contract that we have with government, this kind of basic human right to have access to water? Like, but they stepped in. And there's so many more examples where philanthropy stepped in, where maybe traditionally it wasn't always kind of their job, but somebody had to step in and had to step in quickly. And there's many, many, many examples. And we are so grateful to philanthropy from our community foundation level to Robert Wood Johnson Foundation and so many more that have stepped up to kind of fill in the gaps, build capacity, and help us not only recover but thrive and now really kind of share our lessons learned and best practices, so there are no more Flints. And I want to kind of echo what was something that Tony said earlier. When the pandemic happened, I was actually I can't say happy, but I was giddy, because after Flint's crisis, for so long, we were talking about the failures that made it happen. And on top of list was this failure of investing in public health, of prioritizing public health. And we felt it in Flint. And then we went through are still going through this generation defining crisis. And the whole nation is now opening their eyes to the consequences of public health disinvestment. Like, we knew this. There's no amount of ventilators or ICUs that, or medication that could, save us. So I'm hopeful. I'm excited that, you know, the lessons of Flint are the same lessons of this pandemic, and that hopefully, once again, it will give us this moment where we can turn a crisis into an opportunity to reimagine and prioritize public health.
Awesome. And so you're both describing, again, a sort of a similar barrier that as foundations or as philanthropy, we're often reluctant to jump into what clearly seems like a public health function, a pandemic, you know, lead in the water. Those are definitely governmental functions. But in a crisis, it seems that, you know, in both the case in California with the 21 foundations that came together for a fund, and in Flint where the community and even national foundations came together, we just suck it up and fill in gaps. But I think a question for us in terms of barriers is, how do we sustain philanthropy's involvement in shoring up funding for public health after the crisis has passed? And I think in particular, in both cases with COVID and with the water crisis, frankly, there has been a bit of damage to trust in public health, some perhaps warranted, some unwarranted, perhaps, as public health has fallen prey to some political pitfalls. Anthony talked about public health being political. Well, in the case of COVID, it was political in an unfortunate way that, you know, ended up with perhaps some mistrust of public health that was not really warranted. So we've talked about trust a bit in this conference, actually, in various plenaries, and it's hard to sort of engage with an entity where trust needs to be rebuilt. So I guess one question for both of you is, how can we go about, again, working through our sort of qualms about working in a government space, perhaps rebuilding trust with public health, and doing what's needed to try to get the kind of sustained investments that are really what's going to end up preventing the next crisis, and frankly, giving us the kind of public health resources that we need to deal with inequities, which are not crisis-oriented activities.
Yeah, I think this is the root of the problem. And so let me start by, you know, describing what I think is an appropriate role for philanthropy. Because I don't think philanthropy should be backfilling government. That is a black hole. Government has way more money and has responsibility, transparency, accountability that is baked into some of the rules. Now, some of those rules are awkward and stifling, but philanthropy has none of that. Philanthropy is a secret black box, and it doesn't have the kind of money the government has, nor should it. But one appropriate role for philanthropy is underlying all of this disinvestment in prevention in general. And it's true in the educational space, it's true in the employment space, it's true in infrastructure, is this narrative that government can't do anything right. And that government is the problem, and we need to make it small and drown it in the bathtub. All of that kind of story of government being inadequate to the task. And that's a conscious narrative being generated by certain elements in this country. And philanthropy can play a role in changing that narrative, telling compelling stories and facilitating the telling of compelling stories of government, essentially. And COVID-19 is one of those stories. I mean, you think of the vaccination effort, you think of, the testing effort, we all know that there were huge flaws and it was slow, and certainly our national government fell down, on the task. And not just the Trump administration, by the way, prior administrations, when it comes to the national strategic stockpile and all of these things. But there's a role for telling the story of, government as that sort of collective instrument for, making the critical investments in rebuilding our social contract. And COVID-19 is a beautiful story of that. The second thing that philanthropy, is, and it's squarely within philanthropy's lane, is funding advocacy and helping build that political constituency for prevention. I mean, it's the same thing with early childhood education, access to parks and recreation. You need a constituency to drive decision makers towards equitable investments in these health protective resources. And philanthropy can do that. And it's something government can't really do, because government is, kind of handcuffed when it comes to advocating on its own behalf, or, even kind of participating. People that are professionals within public health organizations are precluded in many instances from lobbying or advocating in any way. So it's like they're gagged, and philanthropy is not gagged. So there's a role both in building and supporting that narrative around the critical role of government in prevention, particularly when it comes to equity, and then helping build a constituency for prevention and equity in sort of government action. But I don't think philanthropy should be redirecting the water system of Flint, Michigan. I'm glad the Mott Foundation did that, but I don't think that that's the role of philanthropy. I also don't think it's the role of philanthropy to be funding specific direct services that the government hasn't done, except in a crisis, like for instance, at the border in California or Texas, where there's a huge compelling need and government is slow to gear up its response. Philanthropy can play a critical role there, but it shouldn't stay there. It should be thinking always, 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 how do I get upstream? How do I change the conditions that created this crisis in the first place?
I'm sorry, I wasn't allowed to mute myself. I did. I'm so sorry, but I just want to jump in and echo that. And I was looking for a line in my book where I said almost the exact same thing. I said, can you hear me? Yeah, okay. If I had to locate an exact cause of the crisis above all others, it would be the ideology of extreme austerity and all government is bad government. The state of Michigan didn't need less government. It needed more and better government, responsible and effective government. The story of Flint and what we've gone through the pandemic, just like Tony said, the lessons is not that this is a failure of government, but that this is what government's for. And the reason that we are often in these crises because we have strangled governmental agencies. Investigations that were done in Flint that looked at the root cause of the crisis was, pointing to these bureaucracies that over decades, because of attacks on big government, had hardly any staff, had no funding, had no institutional memory, it was impossible for them to be proactive. So I completely agree with you. We need robust investment, in government, but to be, once again, transparent and responsive and representative. And that was part of Flint's problem. We didn't have representation, and it wasn't a whole democracy. And then to Tony's second point, which was also wonderful, the piece on advocacy. So right now, the child tax credit is one example, which is temporary, which has this amazing, which was part of the CARES Act to the potential to cut child poverty in half in 1 year. Like, this is something that, advocates and public health folks pediatricians have been dreaming for so long, have been working on for decades. This has transformational, multi-generational impact, but right now it's temporary. So, this addresses equity and environmental justice and racism, everything. This tax credit addresses everything. So if all of the foundations got together and did massive advocacy on this just one issue, encouraging your members and, campaigns and billboards, whatever, to make this child tax credit permanent and to lift millions of children out of poverty, that is something where foundations can play such a pivotal role. And that's just one example, but absolutely in terms of advocacy.
So you all are getting a number of amens from the audience here. They're definitely concurring with what you're saying. But folks, there's time built in here to also get your questions answered. These are two of the best. And so feel free to put questions into the chat as well. I promise I will take time out of the questions that we have prepared to ask them. So jump in there. But I really appreciate what you all are saying about investing in public health. Let's get a little specific here. I've already heard you mention, Mona, data systems and surveillance systems that are underfunded. You both have mentioned staff and workforce in a way, but what are some of the things that we need to invest in? If we need more investments in particularly this form of government, public health, what are folks needing to invest in? Where are we needing to shore up our public health system?
Well, there's a huge need just in core epidemiology. Epidemiology is basically telling the story of disease. And, many of our health departments across the country struggled to tell the story in real time of what was happening in their communities. And so, in order to design interventions, you need real-time surveillance. You need to know where the leading edge of the disease is. You need to know, who's being, victimized, who are the most vulnerable. And a lot of that data, I found frustratingly either absent or very slow to be provided from local public health departments, largely because they lack the epidemiological capacity to do the analysis. And when they did the analysis, they were very uncertain about it and cautious, and they didn't have peers to essentially run their sort of, standards against. So core epidemiology is absolutely huge. There's ways of doing that also on a regional basis to, create, as we've done in California. We have the Bay Area Regional Health and Equities Initiative. We have the Southern California sort of regional chronic disease prevention initiative, which is a regional epidemiologic effort that created essentially the tool that the state used, the equity tool called a Healthy Places Index, that the state used to essentially hold counties accountable as they moved from tier to tier for ensuring that they provided testing and vaccinations to the most vulnerable neighborhoods and zip codes within their county. So these were really practical tools that were philanthropy funded, that created an enormous advantage when it came to holding some of these political entities accountable for equity. So core epidemiology. And then the second thing that I just can't not mention is communications. Oh my goodness, some of the communications coming out of public health departments were so bad. They were indecipherable. And it wasn't because they weren't trying to communicate, they just didn't have communications expertise. So they were saying things that only like 5 people in the country could understand. And that's not how you communicate in a crisis. People are already having a hard time hearing. You've got to be clear. You've got to address the things that are front of mind for people. You've got to go right there. And our public health department struggled with that. And we ended up, many of the philanthropic entities in California funding communication support for our public health departments, who were under enormous amount of pressure. I mean, some of them had death threats, some got, I mean, this was a crisis on top of a crisis on top of a crisis. So core epidemiology, critical communication support, those are absolutely essential. And they're not just for a crisis, they're appropriate to chronic disease and equity as well. And then finally, my public health colleagues would be angry at me if I didn't mention laboratory. Laboratory is, I mean, it sounds boring. It sounds like, a weird exotic infrastructure, but it's absolutely critical. Many of the lab directors around the country are retiring. Many of the labs are woefully understaffed. Their ability to develop the kind of testing that's necessary to sort of manage an infectious disease outbreak has been diminished substantially. There was an investment in public health laboratory infrastructure probably 10, 15 years ago in creating a workforce for public health laboratory directors that has since lapsed. So many of them will tell you that they need these kind of core functions. I'll tell you honestly, there's almost nothing in public health that doesn't need an infusion of resources. I'm sorry to say it, but it's almost across the board.
I agree with everything Tony said. I always agree with everything he says. He's awesome. It's once again great to be here with you. And I think Tony's really kind of addressed what a health department, a public health department at the state and county level needs. And I want to kind of pivot back even a little more, like, what do we need as a society to be healthy that we don't have? Like, where are those, missed investments? And there's many. So, if we are truly hoping to build equity, and if we truly are addressing racism as a public health crisis, then we need investments in reparations and resources to address the wealth gap and to address these long-standing inequities. So that's a big issue. Another one is in terms of our environmental policies. They're terrible. Most of them are lax. They haven't caught up with science. We are reactive. We're not focused on primary prevention. It's great that the Biden administration is looking to get rid of all of our lead pipes, but there's lead in homes. There's lots of other contaminants out there that we only reactively address. We need stronger environmental health regulations to make people healthy. Other critical ingredients for people to be healthy are families with living wage jobs. So public health should be out there advocating for a raise in the minimum wage, that the minimum wage is a living wage with benefits and healthcare and all this infrastructure, so parents don't have to work multiple jobs. Addressing income inequality, which is a crisis. We are at this massive widening, a point of widening income inequality. We talked about child poverty. Like, my list is long, but there's a lot that public health needs to invest in to once again keep people healthy. We could talk forever about early childhood. We could talk about uncoupling healthcare to employment. There's so much that needs to be done to think, and these are not crazy pie in the sky things. These are standards in other countries, and we can get there.
Well, this is rich. I hope you all didn't miss that. And it's so masterful the way you all, you're the perfect panelists to have together, because Tony helped us to focus in on some of those core public health functions, like the epidemiology and the laboratory functions. And you both also touched on those other functions of public health. A lot of folks do not realize that policy development, advocating for things like, let's hear it, reparations, living wages, those are part of the extended public health functions, provided that you have enough basic resources to do your essential services. Public health is also very much involved in policy development, and also a lot of the regulations, even just within public health that you have within your purview. Many of the environmental policies, those things are interpreted through state and local public health. And so I appreciate you all lifting up those things that need to be invested in. We've got a couple of questions though from the audience. One is around partnerships. We know those are very important. An audience member wants to know what other sectors, aside from the government, may be good allies to help resource and support and amplify public health locally. Specifically, they do want to know about, say, the opportunity for the private sector.
Well, obviously, I mean, maybe it's not so obvious, but it's very obvious to me. The healthcare sector has a critical role. And, we talk about the healthcare sector leaning into community, getting outside the four walls of the hospital or the clinic, using the example of Dr. Hannah Atisha, and leaning into that community to try to understand what's driving the phenomenon that you're seeing in your 15-minute intervals in a cubicle, and getting closer to the root causes. Obviously, there's $3.7 trillion in our healthcare system. It doesn't need philanthropic dollars. We need to pull some of those resources forward into community. And how we do that, philanthropy can play a role in that. But I'm not talking about philanthropy supplanting healthcare. That's not what I'm talking about. The other sector that we found kind of a mixed result with COVID-19 is the tech sector. We have a lot of support from technology and tech companies in terms of apps and a variety of different things that helped us be a little closer to real-time data. with COVID-19, but we also saw some major barriers and the digital divide manifesting itself in the tech sector when some of our testing sites required you to have a Google account to essentially sign up to be tested for COVID-19, which was, obviously not workable for a huge segment of the population, particularly the population that was most impacted by COVID-19. So those are two. So I should say that, in our pooled fund, there were a number of just corporate philanthropic entities that participated, particularly in the food service industry that were concerned about farm workers and were concerned about, people all along the food distribution line. And so they have an interest in the well-being of their employees. And so participating in pooled efforts to support the mitigation of COVID-19 was in their financial interest. So we did see some efforts being made there, and I think more efforts could be made. The last thing I'll say is that, at least on the healthcare sector, one of the biggest barriers, and I know Dr. Hanatisha, she described it earlier, is data. Being able to sort of extract data from healthcare delivery systems that are so fragmented in sort of a central database for public health to do population level data analysis. That has been a major legal issue in California. And it's not because of HIPAA, by the way. And in other states, there are other state laws that make it hard for public health entities to essentially get data from healthcare entities and be able to use that data both to anticipate, epidemics or outbreaks, and to do analysis to look at disparities and inequity. So breaking down those barriers, which are largely there, you can surmount those barriers, but people in their minds think that there's somehow HIPAA is the problem, and it is not.
Yeah, I would echo those partners, and I think the most important sector that we work in our public health space is the impacted community. So I think we hear about this a lot. The need to be community partnered, community informed, community driven, and for Flint, that was super important because our story, like I briefly mentioned earlier, was this anti-democracy story where we lost representation and people's voices weren't being heard. So in our recovery work, it was so critical to have participatory democracy and self-determination and have the community's voices wholly at the table. But that's not unique to Flint. Once again, many of us are working in communities that have minimal representation, where they've been suppressed, where they haven't had the ability to have a real seat at the table. So we've kind of formalized that sector work with advisory boards, and we have a group of parents that represent like every ward of the city. And one of my favorite things is we have a group of children that inform our work, and they've named themselves the Flint Youth Justice League, and they're just a group of badass kids. They're amazing. We just released our annual State of Flint Kids, and like, how can we release a report on kids without talking to our kids? And they created this amazing video and told us what's important to them and what we should work on in public health. Like, we may think it's water, but they're worried about safety in their neighborhood, and they hate their school lunches and all these other problems and the digital divide. So it's in all of our work, it really has to be done in humble, shoulder to shoulder partnership with the communities that we're privileged to work in.
I appreciate that point about the communities. I'll tell you, time is flying. We've got a little more than 10 minutes left, and the questions are rolling in. So I'm going to direct them to one of you in the interest of time. While you're talking, Mona, about Michigan, someone wants to know how things are standing today in Flint, and they want to know how folks are doing and what you're hoping to see going forward there.
Good. I'll just spend about 2 hours on this answer. We're almost done replacing our lead pipes, which is amazing. We're going to be the third city to do that. We might, Newark, New Jersey might beat us, but we also mentioned how this might be a national project to replace some of lead pipes. So Flint is kind of really serving as a model, to a national model to do this work so that nobody has to drink contaminated water. And then I get to spend my day making sure that the kids have the brightest future possible, really kind of leaning on the science of trauma and early early adversity and holistically looking at this crisis as one bad thing on top of lots of bad things. And how do we take a step back and how do we use this crisis as an opportunity to reimagine? So we have robust investment in early literacy and early education, and breastfeeding programs and home supports and parenting supports and nutrition prescriptions, and the list goes on. And all of this is by and large because of philanthropy and their partnership. And I spend every day writing grants. So thank you for supporting this work, which is long-term work, which once again we hope to make sure is not just about Flint, but really speaks to crises all over, and even those silent crises that are chronic, and how we need to do better, especially on behalf of our kids.
It's fantastic. The pediatrician in me is very happy to hear that. Tony, I'll direct this one to you since you're obviously a philanthropic leader. Folks love the point about philanthropy's role in lifting up stories and also building the evidence around the impact of public policy. Specifically, the American Rescue Plan was mentioned. But the question is, do you know if philanthropies or any philanthropies are partnering to support such impact studies?
Impact studies around government.
Around the impact of public policy, or that's.
Oh yeah, absolutely. That's kind of a critical role of philanthropy. I think that philanthropy takes on quite readily. Looking at impact studies, looking at evaluation, doing learning, funding think tanks to do policy analysis. That's pretty traditional philanthropic work. I think there's an embedded question in there around changing the narrative around the role of government and, the constituent kind of stories and data you need to essentially build the case for government. And I think that there we could use some more work, more critical thinking around, how do you sort of bend the narrative that has been very consciously created to essentially diminish government. Their philanthropy can play a much larger role, and there are some great thinkers around this issue. John Powell at the Othering and Belonging Institute at UC Berkeley has done some great thinking around that and has been funded to help craft a sort of a larger narrative. And I think that kind of work, and he's not alone, there are others that are working on this as well, is absolutely critical in this moment. We've come to the absolute recognition at the California Endowment that you can't just change policy. Mm-hmm. Policy is essentially derivative of narrative. And so if you want to affect policy, you have to start with narrative. And narrative is story. It's a story of how we describe who we are as Americans or Michiganders or Californians. Who are we? What do we value? What do we prioritize? That's the narrative that has to be constructed in order to drive policy. And then policy creates conditions like lead in the water and COVID-19 disproportionality. So the mistake we often make is we think policy is the sort of like the entry point for this work, and it's not. The entry point is narrative. It's the story. And some folks on the, on the conservative side of the spectrum recognize that a long time ago, which is why this narrative about, shrinking government is in the way, government is a problem, taxes are the enemy. That narrative creates policy that creates conditions that we end up dealing with in the emergency room. So we have to collectively work on that story, on that narrative. And we have example after example of doing that successfully out here in California and elsewhere in the country. So it's very doable.
So to that point, we did get a clarification. The question is about the impact specifically of the American Rescue Plan Act. So that's one case in which, government is making a huge investment. And I think the audience member is making the point that, we need to then study the impact of that so we can tell the story of how that was a helpful thing, to your point about changing the narrative. And I hope that some of us as foundations are funding.
Yeah, and I'll quickly say, yes, we're working on it. In fact, your leader, Kara, has brought us together around that issue, to look at opportunities around the American Rescue Plan to essentially support community engagement and community prioritization. We've actually been asked by the Biden administration to take a look at some models in California for deep and robust community engagement in this process, and some are now trying to figure out, how to do. We didn't expect them to say yes, but we suggested this, and they said, yeah, show us how that's done. We're like, uh-oh. So a way to make this happen, and you can thank the leadership of CARA actually in bringing a number of philanthropic leaders together to start talking about this several months ago.
Awesome. So we've got another specific question, I think, for you, Anthony, and it's about public health accreditation and whether or not you think that is something that philanthropy should invest in.
Yeah, I do. I mean, I don't think it's a panacea. I think, there are many accredited departments that have done a lot of good work. It improves essentially their political governance, of their work and the political understanding of what the public health department does, particularly in places where, public health is really kind of under the radar. Having an accredited public health department can be good for their credibility. The accreditation process has been modified to centralize notions of equity and analysis of sort of racial disparities and inequities. And so I'm very proud that process is not just a sort of a traditional sort of professional kind of assessment, but it's also about how do these departments center racial equity in their work. But it's not a panacea. You can have an accredited health department that's still woefully underinvested in, and many of the elements of accreditation can be an argument in a health department to say, if you don't fund this, we will lose our accreditation. And that can help some health departments, but it hasn't stopped some political entities from just saying so. And so you need a political constituency. You need community that has invested in public health and prevention as a priority. And you can build that constituency. I mean, you don't have to use words like prevention or even public health. I mean, when you're talking about essentially inequity, you're talking about prevention. And if you can organize communities around investing in eliminating inequity, you're creating a constituency for core public health. And that's what's absolutely critical.
Awesome. So Anthony, you actually touched on really what I'm sort of combining two questions, which is just sort of how can we any other final thoughts about how we can support public health, and I think particularly to achieve equity. So I appreciate that you said that. So I'll give you, Mona, an opportunity if there's anything that you want to add about how we can support public health to be able to better participate in this fight for equity.
Yeah, I would just echo the power of storytelling. I think this past year especially has taught us the power of science, but especially the power of science coupled with storytelling. I have many examples where I've talked to especially policymakers, and I share the science and graphs and statistics, and like eyes glaze over. But when I tell them a story about a child and their family, they're on board. So we need to do a better job telling stories. And in terms of narratives, I think another narrative that we have to tackle is health and healthcare. Health is not equivalent to healthcare. Keeping people healthy is not the same as the sickness-based system that we have in healthcare, and thus we should look at how much we fund each, and maybe work at something that has more parity.
So this has been a riveting discussion. I wish we could go on for another hour, but I think we're standing between someone's cocktail or dinner or something for that nature. So I'm going to give you the last question, and then I'll summarize a couple things and let you answer it. We want to end on a hopeful note, a positive note. You guys have already done that. I feel very hopeful about the future of public health. But the final question is going to be, if we do what we need to do and reprioritize public health, what is the good news headline that you expect to read in 5 years about public health? Okay, before you answer that, for those of us who are wondering again, what can we do in philanthropy to help our colleagues in public health achieve the health outcomes that we'd all like to see? We've learned that one, we need to learn about public health. We need to familiarize ourselves with the infrastructure and the way that it works in our respective states. We need to go ahead and invest, particularly when there's a crisis. And we need to be able to change the narrative that was very much reiterated by both of our speakers. And we need to fund advocacy, especially as it relates to equity. So what's that good news headline?
I'm reading it right now. It's going to be that we have built a just and equitable future.
Oh.
Mine is very practical, and it relates to the elimination of disparities in third grade reading scores across all racial groups in the United States. If we can do that, we can cut the budgets quite easily of most public health departments because they won't need them.
That's a world we can all hope for in both cases. Thank you both so much for participating in this panel. You're wonderful speakers, wonderful people. I appreciate it. Thank you, GIH, for planning this thoughtful discussion today. And again, thank you to all of you for joining us. We hope that you have heard something that you have learned about and can put into practice in your day-to-day work. Thank you so much.
Wow. Laura, Mona, Tony, thank you for your wisdom, your passion, your guidance. You were perfect. And thank you all for joining us for the second day of GIH's annual conference on health philanthropy. I'm afraid you can't leave just yet, no matter what the agenda says. I want to give you a quick preview of tomorrow's agenda. So we'll reconvene at 1 p.m. Eastern Time with a plenary session on climate change, health, and equity. We'll have another round of breakout sessions at 2 o'clock, another round of networking sessions at 3 o'clock, and then our closing plenary for tomorrow will be focused on behavioral health. We'll then go into a social hour that allows us to connect and have fun. I'll be there, and I hope you will too. So thank you so much for joining us today. Have a wonderful evening, and we'll see you tomorrow.